Welcome to this explainer. Today, we're diving straight into the clinical details of cerebrospinal fluid, or CSF, shunt complications. We are going to walk methodically, step by step, from the operating room all the way to the emergency room. Our goal here is to give you a highly structured, crystal clear breakdown so you absolutely never miss a beat when evaluating a patient with a shunt. Let's get to it.
Here is our roadmap for today. 1. Insertion risks. 2. Established problems. 3. History check. 4. Physical exam. And 5. Hardware and pumping.
Section 1. Risks associated with shunt insertion.
Okay, right off the bat, there's a critical number you need to lock in your head. 4%. You see, there's about a 4% risk of intraparenchymal or intraventricular hemorrhage during the actual insertion. And remember, that 4% baseline assumes the patient has absolutely zero underlying coagulopathy.
Now, beyond bleeding, we've got a few other immediate post-insertion complications to watch like a hawk. First, the procedure itself carries a risk of inducing brand new seizures. Then there's the mechanical risk of malpositioning. The tubing ends up in the wrong spot, whether that's the ventricular catheter up in the brain or the distal catheter down below. And obviously, anytime you're introducing foreign hardware into the body, immediate infection is always right there at the top of the worry list.
Section 2. Problems in patients with established shunts.
So once a shunt is well established, things can still go wrong, right? We basically divide these long-term functional failures into two distinct camps: undershunting and overshunting. Undershunting is exactly what it sounds like, not enough drainage. This is usually due to an obstruction, which frankly happens at a rate of about 10% per year, or can happen if the tubing actually breaks and migrates. On the flip side, overshunting drains too much fluid. That leads to a totally different set of headaches, literally. It can cause slit ventricle syndrome, really dangerous subdural hematomas, or postural spinal headaches that get noticeably worse when the patient stands up and get better when they lie flat.
Now here is a massive point about established shunts that you absolutely cannot overlook: infection. The incidence rate here has a huge range, anywhere from 1 to 40%. This isn't just a minor hiccup, it's incredibly serious. Why? Because getting a shunt infection is actually documented to decrease a patient's IQ over time. Plus, these infections very often go hand in hand with an obstruction, which just makes the whole clinical picture that much messier.
You also need to physically assess for hardware-specific issues point by point. First, check that distal catheter, whether it's sitting in the peritoneal cavity or the atrium. Next, look closely at the skin over the hardware. Any skin breakdown is a glaring red flag. Now, it might be an underlying infection, but keep in mind, it could also just be a localized silicone allergy. And again, always keep an eye out for the onset of new seizures.
Section 3. Evaluation. The patient history.
Let's step into the clinic. When you're interviewing older children and adults, you're listening specifically for those acute, classic symptoms of increased intracranial pressure, or ICP. We're talking posture-related headaches, persistent nausea and vomiting, visual changes like diplopia or double vision, lethargy, ataxia, and any new or worsening seizures.
But hey, infants are a totally different ballgame. You obviously can't rely on a baby to tell you they have a headache, right? So you have to meticulously comb through their history with the parents. You're looking for episodes of apnea, bradycardia, intense irritability, and poor feeding. Those are their silent alarms for increased ICP.
Next up, you want to screen the history for infection: fevers, chills, night sweats, localized redness or tenderness over the shunt tract, the usual suspects. But here's a brilliant clinical pearl for you. Always ask if they've had diarrhea or been around sick contacts. Because sometimes they just caught a random gastrointestinal bug, and the symptoms are totally unrelated to the shunt itself.
Finally, before you move on, you absolutely must grab their explicit shunt history. Think of it as mapping the territory. What specific type of shunt is it? Ventriculoperitoneal, ventriculoatrial, pleural, lumboperitoneal. Why was it put in, like post-meningitis, and at what age? When was their last revision, and why did they need it? Oh, and do they have any accessory hardware, like an anti-siphon device? You need this entire map before you start navigating the physical exam.
Section 4. Evaluation. The physical exam.
All right, history is locked down. Now we hunt for objective, measurable signs of increased ICP. For kids, step number 1 is always measuring the OFC, the occipitofrontal circumference. But just jotting down the number isn't enough. You literally have to plot it on normal growth curves. You're looking to see if their head growth is crossing percentile lines upwards. If it is, that's a massive indicator of expanding volume inside the skull.
Next, if you've got an infant with an open fontanelle, gently palpate it. A soft, pulsating fontanelle that varies with their breathing? Completely normal. But here's the contrast. A tense, bulging fontanelle screams obstruction. On the other hand, if it's sunken, you might be looking at overshunting or just normal pressure.
Moving to the eyes, you have to check for an upward gaze palsy. This is classically known as the setting sun sign or Perinaud's syndrome. Basically, those expanding ventricles are putting downward pressure directly on the dorsal midbrain, specifically the superior colliculus, which physically prevents the patient's eyes from looking up.
Let's round out the physical exam by checking a few other key things point by point. First, check for an abducens palsy. But remember, this is a classic false localizing sign. It's just caused by generalized pressure stretching that sixth cranial nerve. Second, check their vision for any field cuts or outright blindness. And lastly, actually feel around the tubing for swelling. Sometimes, CSF dissects along the tract of an obstructed shunt, and you can feel it right there under the skin.
Section 5, Assessing Shunt Hardware and Pumping.
Now for the final piece of the puzzle. But wait, before your fingers even touch that valve to pump it, listen to this huge clinical caution. Manually pumping the shunt is highly controversial. Why? Because you could actually make an obstruction worse. If the shunt is occluded by ependyma because of overshunting causing slit ventricles, vigorously pumping it might just suck that brain tissue right into the catheter holes, making the blockage permanent. So, tread very carefully.
If you do proceed to test the pump, it's like a tactile puzzle. You're looking for two mechanical clues. First, if the valve is incredibly difficult to depress, it suggests the fluid has nowhere to go downstream. That points to a distal occlusion. But if you press it and it takes longer than the normal 15 to 30 seconds to refill, that suggests a proximal or ventricular occlusion, or maybe the presence of those slit ventricles that are just starving the valve of fluid.
As you wrap up, do a final check. Run your hands along the hardware to see if any CSF is dissecting outside the shunt tubing. And here is one last brilliant differential diagnosis point to keep in your back pocket. If you have a child with cerebral palsy who has a feeding gastrostomy tube and their only symptom is vomiting, you absolutely must rule out gastroesophageal reflux, or GERD, first, before jumping to the conclusion that the shunt is failing.
So, having walked step by step through every single complication, risk, and exam finding from our source material, ask yourself this. When a highly complex patient rolls into your ER with overlapping, confusing symptoms of both under- and overshunting, how will applying this exact methodical checklist transform your clinical decision-making process? I hope this explainer helps you out the next time you face this clinical challenge. Thanks for joining me, and keep learning.